Okay, ventricular arrhythmias, these will be faster here when we're going through this. The conduction system and muscle fibers of the ventricles may send out electrical impulses that bring about cardiac depolarization and contraction. So that's what we're looking at, is the cardiac depolarization and contraction having odd signals. So when the ventricles assume the pacemaking functions, the result is a widened QRS complex. So whenever you're looking at a wide QRS complex, that is definitely not normal. So that's something to pay attention to. QRS complex is widened when it's beyond 0.12 seconds. Beyond 0.12 seconds. This usually creates a very wide appearance overall. So reasons for this type of configuration: the depolarization of the wave must follow abnormal pathways, and that's why it's sort of a widened complex. It's going a different alternate route, right? It's like going around a traffic accident. It's going to take some time. So these are abnormal pathways when traveling through the ventricles. So the impulse travels more slowly along these abnormal pathways, causing the QRS interval to look wide. So think about driving through the mountains. You have to get around a mountain, so you're driving all these curvy places, so it takes a little while, right? Kind of an odd situation. So when we're looking at PVCs, this is a premature ventricular contraction, very similar to PACs, except for instead of atrial contraction prematurely, it's a ventricle that contracts prematurely. So we're looking at the heartbeat coming early. Instead of originating from the SAAV nodes, it's actually originating within the ventricles. This is called premature ventricular contraction. It is an ectopic site in either the right or the left ventricle that initiates the impulse before it's time for the next impulse from the SA node. So in other words, the SA node is doing its thing, and then somewhere, something outside of the SA node initiates conduction through the ventricles. So the ventricle is like, oh, we got conduction, they'll contract. So it's an ectopic, it's not route that causes it. So a complex coming close behind the complex of the abnormal rhythm. So a complex coming close behind the complex of an dominant rhythm. Sorry. A complex coming close behind the complex of a dominant rhythm. So a wide, bizarre-looking QRS complex is the big thing to pay attention to here. Noticeably different configuration from the QRS complexes of normal beats. So here you see a little strip at the bottom of this slide, and you're looking at PQRS, 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 and then you have this really wide, funky-looking widened QRS complex. And that's what you see. The ectopic site in the ventricles will fire before the SA node can. So do you notice in these there's a T wave, but there's no P wave, but now there's a QRS complex. And then we go to a P, QRST, P, QRST, P, QRS, T, and then no P wave, and then you have a QRS, and it's a wide QRS. So the P waves usually do not precede a PVC. So you will not see a P wave before a PVC. PVCs typically do not cause retrograde depolarization of the atria. In other words, the electrical activity will not go backwards and cause the atria to contract. That's very odd. It's usually designed to go one direction. Sort of like lymph nodes, right? It's designed for fluid to flow in one direction. Same thing here. Electrical activity usually doesn't flow backwards. The sinus node may continue to send out its own impulses on schedule. For this reason, normal upright P waves are usually visible following a PVC. So in other words, you'll have your normal stuff, normal P waves, and then somehow you have this funky wide one. Then you'll have normal things reappear again. So the SA node doesn't need to reset like it does in a premature atrial contraction. There's no reset that's needed. It just is going to continue to go about its own pace and its own business. It reset and have a compensatory pause or a non-compensatory issue with it. One of the most important observations to be made about PVC is the frequency or the number of PVCs occurring each minute. An increased number of PVCs indicates an increasing irritability of the ventricular myocardium. In other words, the heart is getting more and more irritable, which, just like humans, the more irritable it gets, the more likely bad things are about to happen. PVC is what to look for. Is the pattern or of occurrence? So is it occur sporadically? Right? Is it just completely sporadic, just random? Or is it more occasionally? If it's every second beat, it's called bigeminy. If it's every third beat, it's called trigeminy. PVCs, paired PVCs, there's two more or more PVCs together. You'll see them up here. It's like a couple holding hands. You can have what's called multifocal PVCs, where you have different ectopic sites within the myocardium that's causing it, and that's why they look different. They're coming from different focal points. They have different backgrounds that's causing those to fire. Not usually a great for those patients. Paired PVCs and multifocal PVCs indicate a seriousness of ventricular irritability. So this means the heart muscle is very, very irritable. And so the causes of these PVCs, healthy individuals will have occasional PVCs. When you get really excited or when you're consuming or using alcohol, tobacco, coffee, those things can actually cause PVCs. Suctioning, sneezing, all those things can cause PVCs. So other causes, besides those just random things that we naturally have, we just don't have a heart monitor on us all day long to see that. Myocardial damage, so if there's been history of heart things, acidosis, extreme acid-base imbalances, electrolyte imbalances, of course, we talked about that with that first presentation. Hypoxemia, anytime you deprive a muscle of its oxygen, it's a very bad thing, and PVCs will get it will be a sign of how irritable that cardiac muscle is from not getting its oxygen. Alpha or beta agonist toxicity, yay, pharmacology. Digitalis, too much digitalis, blood pressure medicine. Increased frequency, if you have a lot of PVCs starting to show up, especially if there's like 6 or more, and we'll talk about that in a second. This can go into ventricular tachycardia or ventricular fibrillation, which both of those are very bad. So PVC, this is the more prematurely the PVC occurs in the cardiac cycle, the more dangerously it becomes. So if the PVC is occurring on or at the crest of the T wave, so it's pretty close to the T wave of the previous beat, they're more likely to trigger Vfib, ventricular fibrillation, ultimately. So we don't want it coming right after another complex. It's a very, very bad thing. So if it starts getting closer and closer to that preceding complex, especially that preceding T wave, then we need to aware that we see a pattern that's trending towards that direction and get the experts in there as soon as possible. Increased in frequency is a very bad sign. That means the myocardium is getting even more and more irritated. It is not satisfied with what's currently going on. If you see 6 or more in a minute, that's a very bad sign. These can be paired or multifocal. If it's not quickly treated, then we could easily run into issues with going into V. Treatments of PVCs, eliminate the caffeine, alcohol, and tobacco in use, relieve any excitement, especially emotional stress, things like that. Drugs, lidocaine will help numb things down, so they might give IV lidocaine, procainamide, beryllium, verapamil, continuous drip of whatever drug was successful. They might give them a one-time dose, see if it worked. If not, move to a different drug. If they do find a drug that was successful, like let's say it's procainamide, then they'll go ahead and start procainamide drip ultimately. Lidocaine, procainamide, and beryllium are antiarrhythmics. Verapamil is a calcium channel blocker, so that decreases the amount of calcium to go in there. And it slows the heart rate, calms it down. So remember, calcium in your phases, that's kind of an important key, so that if we do a calcium channel blocker, that actually slows the heart rate down. It will also help decrease blood pressure too. So also, if they have an acid-base imbalance, we should probably fix that, or an electrolyte imbalance. Probably work on that or fix the causes of that. An irritable site, neither the left or right ventricle takes over the complete pacemaking function of the heart. This produces a rapid, regular series of cardiac depolarizations and contractions. So you'll see it via very regular. So if you're looking at the screen here, you see ventricular tachycardia, and you see how regular that is. It just looks like someone scribbling up and down, like an earthquake seismometer there. So a very rapid, regular rate. So the rate is going to usually be between 100 to 200. So the rate will be between 140 to 200 for ventricular tachycardia. And here's what you see. Depolarization appears as a wide QRS complex. Remember, it's an ectopic initiator. Wide QRS complexes coming regularly and very close together. You don't see a lot of space in between those complexes, so that's a bad sign that their ventricles are working very fast, hence ventricular tachycardia. The QRS complexes are wider than 0.12 seconds, because the ventricular depolarization must proceed in a direction opposite to the normal, faster path. The conduction through the ventricles is slower, and that's why it's still, even though it's going at a very rapid rate. The ectopic ventricular impulse usually doesn't go up into the atria. In other words, it won't go backwards. It won't travel backwards up into the atria. It's very odd for the electrical activity to go backwards, so it will not usually do that. The sinus node may be free to send out its own impulses as normal, but its impulses are a lot weaker, or a lot less noted than the ventricles. Remember, the ventricles have a much more powerful strength or conduction. So it has completely, the SA node has completely lost control over the ventricles. The ventricles decided to just go off, do their own things. They're not listening to the SA node anymore. They're done with that. Ventricular tachycardia. P waves may be seen through, to march through the EKG. So you can see on this graphic, you might see them marching, but there's just no relationship to the QRS complex, right? It's not very predictable. You see them, how there's two there, then there's a break, then there's two, there's a break, then there's one. It's very irregular. There's no relationship to the QRS. Once again, the SA is doing its thing. The ventricles are doing their own separate thing. It's not a very healthy relationship, of course. So VTAC is a life-threatening arrhythmia. Once again, it is a life-threatening arrhythmia. I would make note of which arrhythmias are life-threatening. This one's resulting from the irritability of the ventricular muscle. So an emergency situation, whenever you see this, it's an emergent situation. The cause usually will cause them to have a low cardiac output. So their cardiac output, or their blood pressure, if you will just start to decrease significantly. Now, if you see this and a patient's talking to you and moving around and they're cognizant and aware and they have a good pulse, then check your leads. It could be just chest hair, or especially if you put them on one of those vibrating chest vests to help break up mucus, that's a very common sign that it looks like a VTAC, but it's actually not. It's just the leads themselves or the wires cause the situation. So if you see them start to pass out, see VTAC, and then you see they're not responding, they turn pale, their pulses are weak, obviously it's a very bad sign. That's a sign their cardiac output is falling. So patients may have a significant fall in blood pressure. They may lose consciousness. That's usually one of the first things you'll see. Their level of responsiveness is just low. So you need to treat it as soon as possible. So untreated, VTAC may progress to Vfib and death. So if we can get them out of VTAC, the sooner we get them out of VTAC, the better chances we have to prevent Vfib and ultimately to cardiac death. So VTAC is an extended period of a PVC. So it may last for seconds or minutes, and it can happen pretty badly in some of our patients. So 5 in a row is enough to create a short burst of VTAC. So if you see 5 of these in a row, 5 PVCs in a row, it's enough to call it a burst of VTAC. Causes of ventricular tachycardia, ventricular anoxia or ischemia, so no oxygen getting there, so low PO2s, low SiO2s, ischemia, blood flow to the cardiac muscle itself has been impeded, usually from an MI or an air embolism or bone embolism, something like that's caused that not to get blood flow to that muscle, and therefore no oxygen or nutrients. Massive amounts of inflammation could easily do it. Digitalis toxicity. Digitalis is a medication given for congestive heart failure. It helps this muscle squeeze harder. It's called a positive inotrope. Helps the muscle squeeze harder. If there's too much of that, that can easily cause ventricular tachycardia. Some pathomimetics, you should know this from pharmacology, could easily send someone into ventricular tachycardia. So the big one here is not your albuterol. Your systemic absorption through anything inhaled is very, very low. So this would be more like IV administration of things like epinephrine can cause ventricular tachycardia. If it's given too much, can easily cause a ventricular tachycardia. It has a very narrow therapeutic index when we're looking at digitalis. That might be one of the things that we have to look at. Are they on digitalis? And obviously PVCs can send as well. Treatment. Oh heavens. If you see this, if there's no pulse, you're going to treat them the same as if it's Vfib. The big thing here is electrical initiation. The sooner you can shock them, the better. This is why they have the pacemakers that they put in patients that also have IED, an internal defibrillator. And there's some good YouTube videos of defibrillators going off, especially of a kid that's playing soccer, collapses on the field, and then you see his body just jerk because his internal defibrillator kicks in and sends electrical activity. His whole body moves, and it defibrillates him. So defibrillate's going to be the biggest, most quick thing. So if we start to see a lot of PVCs start to show up, that's when we usually put pads on a patient and see if we can pace them and figure out the cause of their PVCs. And then if they start to go downhill, we can easily defibrillate if they go into VTAC. Give them oxygen. One of the easiest things we can do. That means the higher the PO2, the better chance we have of getting the myocardium some oxygen and therefore decreasing the irritability of those ventricles. Amiodarone, antiarrhythmic drug, and epinephrine is something else we can do. Epinephrine will help increase the amount of blood flow to the core of the body, and that might actually help. If they have what's called torsades de pointes, it's a rhythm where it's called, literally means, it's French, it means turning of the points. If we do see that, that is a form of VTAC, and that was where we might give something like mag sulfate. And mag sulfate's a really good one for torsades. Not something you might see on a regular basis, but you never know. The worst case of ventricular tachycardia is where it goes into ventricular fibrillation. This is the absolute worst case. You do not want to go into Vfib or see anyone go into Vfib. The entire ventricle muscle will just twitch and quiver. So it's like atrial fibrillation where the muscle is just shaking, like it took too much albuterol, and just shaking and quivering erratically. There's no blood really pumping through the rest of the body. And so it's not effective on contractions. So there's no effective cardiac contractions. The electrical activity is completely chaotic. and all of the myocardial fibers will depolarize and contract independent of each other. So this is the Vfib strip that you see down here. I do expect you to sort of recognize it. There is no PQRST complexes that are discernible. It just looks like Charlie Brown's hair. So the orderly sequence of depolarization is just totally disrupted. And it's very irregular. It is all over the place. It's like AFib, but now the whole AFib. But now it's Vfib because it's the whole thing. There's no blood that's being pumped around the body, so it's a non-perfusing rhythm, which means we need to reset the electrical activity. It's a death-producing arrhythmia. With the onset, the patient usually will lose blood pressure, and their pulse will be absent. So with onset, the patient will lose consciousness, lose blood pressure, and their pulse will be absent. So if you feel a pulse and the patient's talking to you, just check your leads. That might be the easiest of all situations. All right, good old sternal rub will wake them up, see if they're responsive or not. PVCs, causes of ventricular fibrillation. Obviously, too many PVCs where it's the heart's warning you it's irritable. VTAC, that's where the heart's saying I'm really irritated now. Those were all warning signs or precursors. So if they have a person with regular increasing PVCs, increasing, then go to VTAC, then obviously Vfib would be the last one. Treatment of Vfib, defibrillation. This would be unsynchronized. There's no real discernible T wave. Remember, the electrical activity is just all over the place. So you don't have to worry about the electrical activity being messed up because it's very messed up. So unsynchronized cardioversion, unsynchronized defibrillation is going to be the big one. As soon as you can defibrillate these patients, the better. Obviously, we want to do some high-quality CPR until we can get a defibrillator there. Hopefully, they have an internal defibrillator if they're a very sick cardiac patient. One of the things that we can also give is epinephrine to help shunt the blood away from all the distal fingers and toes and send it to the heart to give it more ability to perfuse blood to the brain as well. There's amiodarone, the antiarrhythmic, if they had a very irritated heart, that will help calm the ectopic or the influences that aren't the SA node. It will help numb those out of there. Used to be, they used to teach a precordial thump. If you had a person on the monitor and you witnessed them going into Vfib, that was where that classic thing is where you go and you hit someone in the middle of the chest with one huge blow. And if there's no defibrillator, in theory, you could still do it. I would just worry about all the trauma that's associated with it, but hopefully there's a defibrillator nearby. Or if when you walk into buildings, you're aware where the AED is. When you're looking at this. Finally, we're going to look at cardiac arrest or asystole. This is one of the easiest strips to look at because it's just that flat line going around. All electrical activity and contractions suddenly cease throughout the heart. See no electrical activity. You can't shock this because there's no electrical activity going on. It's like a dead battery. Like you don't charge it by shocking it. Like you have to let it recharge before. So since there's no electrical activity anywhere in the heart during the arrest, only a straight line is usually seen on an EKG. So this is not a shockable rhythm. You do not shock this, unlike what Hollywood think. It is not a shockable rhythm. That's a CPR. That's a compressions. Ventricular standstill is if the electrical activity and the contraction suddenly stops, only in the ventricles, but there's still contraction of the atria. So down here you see in the picture cardiac arrest where there's no movement, but you see tiny little P waves pretty much in there. That means there's electrical activity, but it's just not going to the ventricles. So there's still atria or contraction of the atria, but the evidence of electrical activity in the atria may be seen here. So that means the SA is still going. It's transferred to the rest of it. When you're looking at cardiac arrest and ventricular standstill, the effect and immediate danger is the same. Their cardiac output will be non-existent. blood pressure and pulse will still not be there. The patient will lose consciousness, and if not worked on, it can induce death. So when we're looking at the treatment of choice for ventricular standstill is going to be CPR. So this is not a shockable rhythm. This is a CPR, so chest compressions. You do not defibrillate, so like I said, not a shockable rhythm. If the CPR is working, it may cause the muscle to get more perfusion. And if the muscle gets more perfusion, you might actually come back to ventricular fibrillation. If you come back to Vfib, which is a shockable rhythm, then you defibrillate. So if the CPR causes them to go back into Vfib, good news, we can defibrillate that. If it does not, then we keep doing compressions. Artificial pacing can be given as well. We can also give them a good old epinephrine to help increase blood flow, and atropine also to help reduce any vagal things that might